thrilled to welcome Dr. Sharlene Gill, who is a medical oncologist with lots of clinical experience in treating patients with pancreatic cancer. She is extremely knowledgeable about best patient outcomes when and using treatments such as chemotherapy. She is also the chair of the Gastrointestinal Site Committee, Canadian Cancer Trial Group, is currently the president-elect of the Canadian Association of Medical Oncologists, and editor-in-chief of Current Oncology, a Canadian Cancer Research Journal. So we are very thrilled to have her here and looking forward to seeing her presentation.
Thank you. Again, thank you very much for the invitation. This is a really rare opportunity for me to interact with patients. A lot of my education is very healthcare professional facing, and it's nice to see we have an audience from across Canada as well as the US. So I'm a medical oncologist. I'll tell you a little bit about myself. I'm born and raised in Vancouver, and did most of my training at UBC, and then spent about 3 years in fellowship at the Mayo Clinic in Rochester, focusing on GI oncology, and that was over 20 years ago. So I've been doing this for a while. My area is medical oncology, so chemotherapy, systemic therapy related treatments. And as I've gotten older, and I'm not hopefully wiser, I think our training, foundational training, is very much appropriately ingrained in the science and the evidence, and we continue to push that forward. But I think we start to gain some perspectives and learn a lot from our patients over years of experience. So, I don't have a lot of prepared slides. I'm hoping that this is an opportunity to answer questions as best as I can. And again, thank you for the invitation, and to Craig's cause for the work that you do to raise patient advocacy for pancreatic cancer, because we really need it. So I just kind of call this, let's talk about pancreatic cancer. Very general overview. Some of you, I'm sure, have a very sophisticated knowledge about pancreatic cancer treatment, so I apologize if this is going to be oversimplified, but I did want to leave more time for questions. Why are we in a situation where, despite years and years of efforts, we still recognize that we're not making the progress we should be making in pancreatic cancer? And in the most recent Canadian Cancer Society estimates that came out for 2022, one of the highlights was that pancreatic cancer is, while it's the 11th most common cause in incidence, is that it will be the third leading cause of cancer-related deaths in Canada. And they specifically kind of talk about the fact that the limited progress, I think, in early detection and new treatments, and we're going to talk a little bit about that frustration, kind of explains why we're kind of not making the progress we should be. And it's reflected, unfortunately, in the cancer estimates. We're talking about almost 7,000 new cases, but almost 6,000 related deaths. So therein lies our challenge, and I certainly don't have to, share that with all of you. When we think about the etiology of pancreatic cancer, it's often the diagnosis is insidious. The part of the challenges of early detection is that we don't have a lot of warning symptoms. Almost half of pancreatic cancers are quote unquote sporadic in nature, seemingly random, no clear etiologic or epidemiologic association. We think a third may be related to an increased risk attributable to smoking. That has changed over time. Some of this data is older data. Maybe there is a association with dietary factors, and a small proportion are related to inherited risk. So maybe less than 10%. If we think about quantifying what those risks are, probably from a lifestyle modifiable risk factor perspective, smoking is the most modifiable risk factor with the highest impact. We think it doubles our risk of pancreatic cancer over the course of our lifetime. But other things like diabetes and high body mass index, alcohol use, history of pancreatitis have also been associated. We also know, though, unfortunately, that even many people in the absence of any of these risk factors, still may be diagnosed with pancreatic cancer, and that that speaks to, the sporadic nature of many of the diagnoses in many of the patients that I see. Genetic factors is something we're paying more and more attention to. I think when I first started my training many years ago, we weren't talking about it as much. And I think now it's getting a lot of attention. We think that 1 in 5 patients may have some kind of a family history related to pancreatic cancer. That doesn't necessarily mean it's a defined pancreatic cancer syndrome, which often involves multiple family members, first degree, meaning sibling, parent, child, kind of first degree, across generations. And I think what's gained the most attention has been BRCA germline mutations, both from a hereditary ascertainment perspective, but also we're going to talk about potential predictive biomarker for treatment, the options that may be available. Probably it's estimated now that about half of pancreatic cancers at the time of diagnosis are considered advanced. About a third are considered locally advanced, so no evidence of distant disease, but unfortunately still not resectable. And maybe a quarter are resectable at diagnosis. So where there's a hope that you can completely eradicate disease. This kind of reflects, in cancer care, there are very intentional efforts to try to protocolize treatment approaches. And it's not to take away from the individuality of each case has to be looked at in its own kind of context, but it's to try to standardize treatments and kind of for us to be able to, as we advance the science, appropriately compare outcomes, with a sort of a standardized approach. So in many aspects of healthcare, including cancer, we're all about guidelines and sort of, algorithms. And for pancreatic cancer, this kind of reflects our current state. On the left, patients who have resectable disease, the goal is resection. Increasingly, we're talking a little bit maybe about some treatment before resection. I'll mention that. And then potential chemotherapy after. And for patients with advanced disease, the goal is really on systemic therapy primarily. So, when I kind of meet with patients and we're getting to know one another, I think understanding what our goals are important, like, understanding a person's individual preferences, how they want to receive treatment, their understanding of their diagnosis, how much they want to know, and what is important for them. Is really important. I usually tell patients that I am here to provide you information and a roadmap, but you are driving this bus. So I really need their help for us to be able to do collaborative decision making, because each treatment decision, whatever it might be, surgery, radiation, chemo, as we all know, has a kind of an assessment of risk versus benefit. And the benefits we hope for in cancer care, and certainly in pancreatic cancer, is we want to be able to help our patients live longer and live better. The risks of treatment are often the actual treatment related sort of side effects and risks, but they're also, awareness of toxicities, like quote unquote toxicities related to time toxicity. So when we choose to do treatment, patients have to contribute, and their families are contributing a lot of time. And in situations where the benefit may be modest or in advanced disease, that's a trade-off that people have to, consider and weigh, is that what's important to them? And also in some cases, financial toxicity. We hope that that's less so in Canada, but we still know there are a lot of treatment-related costs that are not funded by the public system. I'm sorry. And this is our toolkit, our sort of, our armamentarium. The fundamentals of this has not changed a lot really in the last 20 years. We talk about surgery. When we can resect, we try to optimize the conditions for resectability and resect disease when there's no evidence of metastatic disease. And then we sort of talk about radiation also as a local treatment, and chemotherapy is a systemic treatment. So what has changed has been the options of systemic therapy that were available. So, again, when I started practice, really all we had was gemcitabine. We have more options now, not a lot more options, but more options in terms of systemic therapy. We kind of, we think about the active cytotoxic, that class of systemic therapy in pancreatic cancer, 5-fluoropyrimidines, 5-fluorouracil, oxaliplatin, irinotecan, often given in combinations, the most common being FOLFIRINOX, so all three in one regimen, kind of on an every 2-week schedule. But sometimes it might be in doublets as well, FOLFOX or FOLFIRI. And then probably the second most common is a gemcitabine-based regimen, often gemcitabine with nab-paclitaxel that goes by the trade name Abraxane. To date, in Canada, I'm kind of focusing on sort of what has Health Canada labels. In the US, I know there are some FDA approvals that are not approved in Canada, but there are no technically established targeted therapies in pancreatic cancer. So targeted therapies is this idea, if you have an actionable mutation that's individualized to that cancer, and by targeting it or blocking it with a drug that can do that, you're achieving some benefit in terms of controlling cancer. And but there are things on that are being researched and on the horizon and in use, and I'll talk a little bit about that. And to date, there's also no established role for immunotherapy. So immunotherapy being the class of drugs that are really designed to try to harness our own T cells, our own immune cells, to try to fight cancer. Pancreatic cancers inherently have not been very sensitive to immunotherapy, and it has not been for a lack of trials trying to establish that benefit. If we start with patients, the 1 in 4 who present with resectable disease, the surgical, so I will see patients after surgery. So often a medical oncologist may not be consulted. However, as I mentioned earlier, increasingly that is changing. There are trials now looking at what is the benefit of chemotherapy before surgery, a quote unquote neoadjuvant approach. But I would say the standard really often is still in patients who have resectable disease to resect it and then consider adjuvant postoperative chemotherapy. The goal of adjuvant chemotherapy is to try to reduce the risk of recurrence. We know that even after, let's say, a Whipple's resection, the risk of cancer coming back is unfortunately still high. And studies have shown, particularly with the FOLFIRINOX regimen, that chemotherapy for a period of 6 months can materially reduce the risk of recurrence. It does not eliminate the risk of recurrence, but it's 6 months of chemo in the hopes of reducing future risk of recurrence. And neoadjuvant therapy, as I mentioned, is this approach of trying to give treatment in the hopes of shrinking cancer. And in pancreatic cancer, the reason why we worry so much about early introduction of chemotherapy is because we know, oftentimes we say pancreatic cancer is a systemic disease, meaning the reason why more than half of patients are presenting with metastatic disease at the time they're diagnosed, by the time they have some symptoms, is often because those cells can spread early. So this idea of what if we start chemo as soon as possible before surgery, can we improve outcomes? And I think that's a question that is currently being looked at. And in Vancouver, we're participating in an alliance-led, US-led North American trial asking that question of neoadjuvant chemotherapy before surgery versus surgery and standard adjuvant chemotherapy. And then, the majority of the patients that I treat have advanced disease, and that is the idea of trying to control disease with systemic therapy, occasionally with radiation, but often that's on a case-by-case basis after multidisciplinary review, because there has not been any consistent data to demonstrate that in advanced disease, radiation helps people live longer or live better up until this point. And it becomes sort of then a discussion with patients about looking at their preferences, their medical situation. Are they able to tolerate a certain chemotherapy over another? And a choice is made. Again, most commonly it is this FOLFIRINOX regimen, because we believe it's probably the most likely to give us better control, but gemcitabine and Abraxane is very commonly used as well. And I mentioned that, this moving the needle, how do we move the needle? These are studies leading up to about 10 years ago, where for many, many years after, I mentioned, gemcitabine initially being the standard of care, we really had a number of what we call negative trials that were done unable to show that they were any better than the current standard of care, until about a decade ago, when we had 2 trials that looked at FOLFIRINOX and gemcitabine and nab-paclitaxel, and gave us some more options to offer our patients. Why is it so hard? Pancreatic cancer, compared to even other cancers, appears to have a very challenging tumor biology. It's driven by sort of mutations in tumor suppressor genes that do not seem to be druggable. There are few predictive biomarkers for all the studies that have been done trying to correlate, find actionable mutations that can be targeted. The microenvironment around a primary pancreatic cancer tumor, this idea of why do we get spread so early, and why is it so hard to deliver treatment, around a cancer, is also quite complex. There's a lot of that stroma, the tumor stroma in that environment has not been very friendly to the use of chemotherapy, systemic therapies, or radiation, and this idea of inherent drug resistance. And so, after the chemotherapy trials that I talked about up until about 10 years ago, in the last decade, there have been a number of studies trying to look at novel approaches to try to, address those barriers in the tumor microenvironment, try to look at immunotherapy. And unfortunately, there's a motivation, obviously, to want to do these studies, and patients have really put themselves forward to participate in the trials, but we still are at a space where we have not really changed that paradigm in terms of upfront chemotherapy, because none of these targeted therapy approaches have demonstrated in a randomized scientific trial context that they actually are any better than current standards of care. One area of promise that represents a smaller proportion of patients with pancreatic cancer, but with sort of very encouraging data, is this concept of DNA damage response. Tumors with DNA damage response mutations and BRCA BRCA mutations, specifically more commonly BRCA2. So this idea of DNA damage response is based on the fact that we know that simplistically, we think about cancer as, as hits to our genome over time, right? And as we, it can be oxidative stress, it can be environmental stress, it can be a stress induced by an inherited predilection. And we have mechanisms over the course of our lifetime to repair those errors that happen in the course of DNA transcription. Unfortunately, in some circumstances, those repair mechanisms may be defective. And so one example of that is BRCA mutation. So BRCA mutation is a mutation. BRCA is normal in its normal function is a tumor suppressor gene. It's responsible for this homologous recombination, the furthest right column mechanism of repair for DNA damage. And when it's mutated, it predisposes us to cancer because those errors don't correct themselves. And we most commonly think of it, as breast ovarian, but now it's recognized that in pancreatic cancer, certain prostate cancers as well. And beyond BRCA1 and 2, there's a family, I guess, of genes that are implicated in DNA damage response that also can carry with them a similar risk. It may or may not be inherited. So it's estimated that less than 7% of patients with pancreatic cancer have a germline BRCA1/2 mutation. 40% of patients who are found to have these mutations don't have a known family history of breast ovarian cancer. And so that was sort of the fallacy from a decade ago, where we would really rely on that kind of a family history. And we do know that the presence of BRCA mutations does seem to be associated with a better response to a certain type of chemotherapy, so platinum-based chemotherapy. And that has been demonstrated in a number of trials that have kind of looked at if we give like a platinum is like oxaliplatin, cisplatin, part of that FOLFIRINOX, FOLFOX regimen. If we give a platinum-based regimen versus let's say gemcitabine, which is not platinum-based, that tumors that harbor BRCA mutations respond much better to platinum-based therapy. We also know now and have known for a few years that BRCA mutations also may predispose us to a better response to a class of drugs called PARP inhibitors. So PARP inhibitors are also responsible for preventing repair of DNA strand breaks. And the idea is that PARP inhibitors on their own are not sufficient to cause enough damage to the DNA of a cancer cell that forces it into what's called apoptosis. So sort of, we call it suicide, cell death. However, if you have a tumor that has a pre-existing BRCA mutation, so already that DNA damage response is impaired, and then you add a PARP inhibitor to it, you can induce a concept called synthetic lethality, where you've caused enough DNA damage to the cancer cell that it will not, it kind of recognizes the futility of trying to repair itself and will die. So forced into apoptosis. And then finally, just I wanted to sort of, we are in 2022 in an era where we hopefully think about oncology more from a precision medicine perspective rather than trying to put everything into a sort of a box. And it's recognized that if you were to do what's called sort of next generation sequencing, so kind of not just look for a point mutation here or a point mutation there, but try to interrogate the whole tumor and see, hey, what do we find that beyond BRCA, with low frequencies, but there are potentially actionable mutations that can be identified through that kind of an approach. And in a study that kind of looked at, well, does that approach, adopting that kind of approach, help patients, again, live better, live longer? This was kind of in this study from the US, over 1,000 patients with pancreatic cancer all had their tumors undergo molecular profiling. About 18% of those, so almost under 1 in 5, there was something identified that was potentially actionable. So that's like, if for those of you who've seen your molecular profile report, so they will list them in tiers often in terms of, yes, this is linked to a standard of care. This is maybe actionable if there's a clinical trial available. And in that environment, under 5% were actually able to be matched and receive a molecularly matched therapy based on their profile. And so if you look at that 5%, in terms of how they did better. Their survival was better. And so the message is that this kind of approach can improve outcomes, but we need better arrows, right? Even if you find a target, we need to figure out how do you turn off that target. And I think it's that gap currently that it's, I'll find our service as well to consider clinical trials were available, in that context. And it takes a team, and the most important team obviously is your personal team, our personal advocates, our family, our friends, our community, fellow patients often. But within the medical team, I'm a medical oncologist. I've kind of talked about one aspect of pancreatic cancer management, but I operate in the context of a broader medical team and often have to lean on them for these kinds of decisions. We have a pancreatic cancer multidisciplinary tumor group where cases are brought forward for discussion, so we can get that kind of input in real time from, I can talk, my radiation oncologist, my hepatobiliary surgeon, my gastroenterologist, and our allied health team. So that's a really important element of what I do, and I really lean on the team to kind of help me serve my patients in the best way I can. And in the discussion of goals of care, where appropriate, many studies have shown that early integration of palliative care is beneficial in the advanced context. So having an honest and thoughtful discussion about how do we best support patients is not just about showing up for our chemo every 2 weeks, but trying to figure out how do we optimize management of symptoms and supportive care and support transitions to end of life care when that time comes. And so that was my kind of very general sort of putting things into context perspective. I'm based in Vancouver, as you heard earlier. That's my Twitter handle if you wanted to reach out, but I'd be happy to take questions or comments.
Yeah, so I have some questions, and people can put them in the chat too, as I'm reading some of them off, but look at a few. So some are quite specific to chemo. So this one question is, when do you decide it's time to change chemo regimens, when CA19-9 rises or when the CT shows changes?
Yeah, it's my upfront disclaimer for all of these questions is that these are very, my comments will be very general, right? Without knowing sort of details of every case, because I have been known to use either sometimes in the right context to have a discussion about change of therapy. We talk about this paradigm of in advanced disease, knowing that we don't have like infinite options, what we call lines of therapy, to kind of milk the most benefit we can out of each line of treatment, but obviously within reason, and not wanting to prematurely abandon a treatment that may still offer us benefit for those goals of trying to live better and live longer. And so, so there's this concept called, treat to treatment failure. And treatment failure is defined by a composite of things. It includes evidence that the cancer is no longer responding to treatment. So those measures that you talked about, a rise in the tumor marker CA19-9, radiographic findings, obvious sort of symptomatic worsening, right? So we think that's okay. That's signs that the cancer is not progressing, is not responding, sorry. And sometimes treatment failure can be intolerability of treatment, where as much as we try to manage the side effects, it's just not working. I most commonly will use radiographic evidence of disease progression. I think in this day and age, we don't want to make a miscall. Like I said, maybe a patient is still benefiting from treatment and rely on the CA19-9 alone. CA19-9 has been around for a long time. It is an imperfect marker. We use it because the trends over time can be helpful. And so often I will use the CA19-9 as a trigger for me to maybe get my scan earlier, not necessarily, and start to get my ducks lined up in a row about what are we going to do next, but not necessarily change treatment solely based on that.
Great, thank you. Okay, I'm gonna ask you this one. How can they manage neuropathy in hands and feet? Would acupuncture help?
I hope so. It's a hard one. Neuropathies, I mean, the most common culprit for neuropathy in our contemporary chemotherapy programs is oxaliplatin. In some cases, people are still receiving cisplatin. That's another platinum, but it's the platinum drugs that do it. Oxaliplatin neuropathy is a bit tricky because it sometimes while we're on treatment, it's manageable. We how's the neuropathy? And then even when you start to try to reduce the dose or modify it, it often can get worse before it may get better. And there have been many studies that have tried to look at things like calcium magnesium infusions and certain, the kinds of medications we use for diabetic neuropathy to see if that would be helpful, with very limited success. And so I am not aware of any studies that have shown that acupuncture is helpful for reducing neuropathy, but I have had many patients who have tried it and with variable success. Part of that, it might, my perspective is if I don't have a better option to offer, I'm not going to say don't try it. But I think I think it may, it may have a, I don't know, it may have a role. And it would be reasonable for a person to consider that if they've really gone through and tried other things and discussed with their oncologist first. So when we talk about advanced pancreatic cancer that has spread, metastatic disease, we know that there are certain sites where pancreatic cancers are more likely to spread to. So that it is liver, lung, and what, the mesentery or the peritoneum, sort of that saran wrap coating over in our abdominal cavity. Typically, we don't dictate choice of chemotherapy based on site of disease. So, and in a setting, and this is not something that is surgically fixable. So it would depend, often we would talk about resuming chemotherapy, depending on how long that chemo break was. And if we had responded to previous treatment well, and it was manageable from a side effect profile, often the first step would be to try to retreat with that same treatment, kind of a re-challenge, in the hopes that may, control the cancer. So, like I said, basically we don't use different chemotherapy options if the disease is peritoneal versus lung versus liver. It's still the same options. So I think any systemic therapy, including an experimental trial, so an antibody drug conjugate is kind of one of these combination drugs where the antibody is meant to try to zone in on some marker that exists on the cancer, and the drug conjugate is the payload of what's going to kill the cancer. It's usually a chemotherapy-based payload. So you're trying to improve the delivery of chemotherapy using the antibody to kind of zero in on it and then deliver that chemo to the cancer. But it's still a systemic treatment, and these are still given through the bloodstreams. So the likely, the peritoneum, it is true what you commented on earlier, that sometimes, the lungs look better, but the peritoneum, had progressed, in that area had progressed. Sometimes it depends on the blood supply to that area, how well the chemo can get to that spot, and lungs are better vascularized, liver is better vascularized, primary pancreatic tumors not so much, peritoneum is somewhere in between. So I think that but as a systemic treatment, that's the hope, is you're trying to treat multiple sites of disease at the same time. I have heard of it. I have heard of it, and I have had patients ask me about it as well. It is, I think it is looked at with a palliative lens, kind of trying to help improve quality of life. One of the issues with peritoneal carcinomatosis over time is that it can be it can predispose us to things like building up fluid and ascites, and how do we try to mitigate that? The concept is the idea is trying to use that aerosolized delivery to kind of bypass the blood system and deliver chemotherapy directly and try to reduce that burden of disease in the lining. You're right, it's not available in Canada, it's not available in BC either, but I think it's something where there is research being done. I think we need a bit more evidence. Yeah, so it's a good question. So there's this anatomic definition of cancer, and then the cell of origin, right? The ampulla is that space, that point where the pancreatic duct and the bile duct enter collectively into the small intestine. So where we're dumping out pancreatic juices into the upper part of the small intestine, and we're dumping bile to help digest food into the small intestine. So kind of that confluence is the ampulla. And cancers, it's very anatomically close, obviously, to the pancreas. It's kind of right there. and the bile duct. And so that anatomic sort of point is called the ampulla. And early studies with pancreatic cancer often would combine, with chemotherapy, pancreatic and ampullary cancers, because it was very difficult to differentiate them. What has happened is, we now, when our pathologists look at, if we have a good biopsy, look at it under the microscope, they're sometimes able to help tell us a little bit by, hey, do these cells look more like pancreatic glandular cells or more like biliary cancer cells? From a systemic therapy point of view, it turns out the same kinds of chemotherapy medications I talked about, like platinum and gemcitabine, are also the same kinds of chemotherapy regimens that are used in biliary cancers. So there is overlap in the chemosensitivity of it. So as a medical oncologist, if I'm being asked to use chemotherapy primarily, we often will look to regimens that may be available for either pancreatic or biliary cancers. For clinical trial eligibility, it does become a bit trickier. We as oncologists don't dictate like who is eligible to be in the trial, and often trials, because they're really trying to really define a benefit in a well, like as best as they're able to define patient population, are very rigid in their criteria. So it's possible if we were to talk about our standard of care chemotherapy, like I said, we would use either options, but sometimes for a trial, and I don't know exactly which trial they're referring to be quite honest, but they would have to refer to, there would have to be some confirmation that it's a pancreatic cancer. So sometimes we will talk about, let's say someone's had a recent surgical procedure or something like that, or they're another illness related, we say, well, hey, maybe this isn't the best timing to ask you to start chemo. Let's try. There is an optimal window. I don't disagree with that, but there isn't I don't think there's generally a concern about starting too early. I'm not sure what that was about. It depends. So when the chemo that was initially used was kind of the adjuvant chemo, we recognized that the whole goal of that adjuvant chemo was to try to reduce the risk of recurrence. And then if the cancer comes back, it's kind of like, well, that didn't do what it was supposed to do. However, it depends a bit on the timing. So we say, if that interval where we were free of cancer, we call that the disease-free interval, was short, meaning I finished adjuvant chemo and 6 months later something showed up, then we would say we're not going to waste our time with that same regimen, probably better to try something different. But if it's longer, and the threshold is usually 6 months, we will often say, hey, maybe there would be benefit. Maybe it wasn't as powerful or impactful in preventing recurrence, but there may still be some sensitivity to try to control the cancer. So often we would re-challenge if it's been long enough, provided that the person's experience with the prior chemo was acceptable, like we had manageable side effects. Like if I'm talking to a patient and they're like, that was miserable, then even if it had been a year, we're not, we wouldn't do it again. In Canada, there's this kind of what's publicly funded standard of care, and then trying to look for other options, right? I think there is a reality around that. So the standard of care recommendation is for BRCA testing. So that's something when they're talking about genetic testing, they are talking about looking for a germline BRCA. Okay. And they are also looking at something called deficient mismatch repair. I didn't talk about that too much, but a few % of patients with pancreatic cancer may have tumors that have deficient mismatch repair, and those may be responsive to immunotherapy on a trial. Right. So that genetic testing is considered standard of care. What I was talking about from the Pishavian study that I mentioned in the trial was like we did this kind of whole next generation sequencing in Canada is not considered standard of care and is typically if there is a trial that can be offered. So, however, I will discuss it with patients and say, if it's something you're interested in doing, there are commercially available assays that unfortunately are not publicly funded, and we hope that will change. But like Foundation Medicine or Tempus or Claris, and they will accept Canadian patients. And Foundation Medicine has a program where they actually will offer a discount, like if Extended Health won't cover it. So I think that's done more commonly now. For many of my patients, I will talk about that.
Can I just jump in there for a second? We've been actually working quite closely with PanCan. Yes. I'm Stephanie with Craig's Cause. We've exchanged letters, Dr. Gill. And actually PanCan does the Know Your Tumor program for free for patients in Canada. So they'll do that genomic testing for free. It's about a $6,000 or $7,000 value. And I guess the turnaround, we've had quite a few patients use the Know Your Tumor program right now through PanCan in Canada. Okay. And the turnaround is usually between 2 or 3 weeks, so it's not even that long. Yeah, the patient and caregiver. So I'm just putting in can you see the link now? I just put the link in the chat box. There'll be a phone number and a referral center there, so you can contact them, and they'll give you all the information that's needed to work with the care team here in Canada.
I mean, I think it's a moving target. I'll often tell patients, if I don't have a cure to offer them, we're talking about situations where I can't promise a cure. I'm not in a position to tell them don't try anything else, but I would want to be part of that discussion and decision making to make sure it's safe. I think there is a concept of integrative oncology that can be beneficial for patients. It depends on, but I try to have a discussion about, well, what are they hoping for? The circumstances where I find it to be most, where patients come back and says most helpful is where they're hoping for things like helping with their diet or their nutrition, or helping with their more sense of well-being. I think it's harder when people are being overpromised an anti-cancer response, and then we have to be, my imperative is to make sure that it does not, it's safe and doesn't conflict with the treatment we are also doing in parallel. So better to be really open and candid about it, and rather than feel like you don't want to tell your oncologist because they might not be positive about it.
Okay. I will jump in there also, and then I'll stop. But for us at Craig's Cause Pancreatic Cancer Society, we've seen a lot of patients and heard a lot of stories over the past 16 years where patients haven't fully disclosed what else they're doing with their medical oncologist. And even simple, Dr. Gill's already touched upon this, but even simple IV vitamin C, it's something that you really want to share with your oncologist team. We've had patients say that their naturopath doctors have said, well, you don't need to tell them that you're doing this, but you do. So you want to make sure that if you're doing any other medications or any other treatments along with chemotherapy, you really need to have the whole team working together and communicating.
Yeah.
Because it can literally, it can stop your chemotherapy.
Yeah, no, I'm glad you highlighted that. Actually, I had a young mother with pancreatic cancer a few years ago who was very motivated in wanting to do integrated approaches, and I think it's a telltale sign if your naturopath tells you don't tell your oncologist. No, I think there are many practitioners who really are trying to figure out a way to help support patients. It's not, I don't have that kind of a negative view, but in this case, so we kind of worked together and figured out a schedule where when she went in for her infusions, it didn't conflict with the dates with her chemo. And we tried to be I tried to accommodate as much as I could within, with that priority of being safe. So yeah, absolutely, like, better to be very transparent about it. Because of I mentioned that tumors that have BRCA2 mutations are more likely to be sensitive to platinum-based therapy. I think the options would be probably a discussion about chemotherapy, but it may not have to be FOLFIRINOX again. 10 months is long enough that you could consider a re-challenge, but there are some studies that look at a combination of cisplatin and gemcitabine, kind of introducing a new medication along with a medication that is a platinum, like oxaliplatin, that have shown very encouraging response rates. So in Canada, the approach would be something platinum-based. It might be 5-FU-oxaliplatin, it might be gemcitabine, cisplatin. That would be the standard approach. And depending on which center you're at, obviously asking, is there a specific clinical trial that would be a consideration as well, I think would be an important question. It is worth talking to your oncologist about, like, I think if there was a trial available, maybe looking at chemotherapy plus a PARP inhibitor, that would be another question. Most trials would reserve the use of trying a PARP inhibitor until after you've had some platinum-based chemotherapy first. So, but I think that those would be good questions to ask your oncologist.
How do I find a medical oncologist experienced in treating pancreatic cancer patients in Montreal or in neighboring cities?
I'd even generalize that, because I think it's a good question.
Or anywhere, yeah, in the country.
Yeah, a lot of patients are just really anywhere. How do you find those medical oncologists that are experienced in treating pancreatic cancer? I know that's
get
asked a lot.
It's so dependent on sort of geography. I think typically we know that certain higher volume centers. So in oncology, there's kind of our community hospitals, community cancer centers, and what we call sort of academic or research cancer centers. And so let's say, hospitals like BC Cancer or Princess Margaret, or in almost all provinces, there's an academic comprehensive cancer center. And in that center, people like me have the luxury of focusing on just one disease site. So I spend all my time and energy researching, treating patients with GI cancers. But my colleagues who are in the community treat everything: breast, ovarian, prostate, you can imagine. And and typically, when I talked about why we have algorithms and why they're so important, is that often the upfront approach is very clear for everyone about what needs to be done. It's when things get more complicated, we're trying to think of different options, are there clinical trials available, that sometimes it's hard for the community oncologist to be able to meet all those kinds of questions, right? So I think it's reasonable. Often we get referred to the oncologist that's within our catchment, like where that's how that process works. But if you are motivated and said, I'd like a second opinion at my regional cancer center, whatever that might be, that's the academic center, I think patients can always ask for that. I see many patients out of my catchment who just want an opinion, who want a second opinion, I think. But there isn't really a name finder that I'm aware of. Are you guys aware of? I'm not where you can kind of search who treats pancreatic cancer.
Yeah, we used to actually, when we first started, we actually were able to find, it was easier to find the names of HPB surgeons. And then with what we've done on our website is we have a patient referral center. So we have paired the HPB surgeons and those hospitals that are a little bit more experienced in treating pancreatic cancer, because if they have the HPB surgeons, then quite often they're working quite closely with the medical oncologists.
Yeah.
We did try to keep up with medical oncologists that were experienced in treating pancreatic cancer, but it just became too laborsome because many were coming and going or switching specialties, or so we were just always scared that it wouldn't be as accurate as it should be. So we've just gone to looking at the different cancer centers that certainly have the HPV teams and oncologists working together, and that seems a lot easier to maintain than specific names.
Yeah, it is a harder challenge.
Yeah.
But I hope that helps.
Yeah.
Well, thank you so much. It was really an honor to be able to kind of sit with you this morning and to be invited. And again, for all the work you do and patients supporting one another, I think that's so imperative. So thank you very much.
Awesome. Thanks again. We appreciate it.
Thank you.
Okay, take care.